I'd like to thank and introduce our panel. On my left is Professor Claire Roberts, on my first right Professor Gus Decker, and second right Professor Jodie Dodd. Now I'm going to spring something on you that you haven't seen before, team, and this is a picture of a newborn baby. I'd like you to have a look at it for me, please. And perhaps if I could start, Jodie, by asking you to describe what you see.
Sure. Well, it's a very, very small baby and is very wasted. So you can see the ribs are very, very prominent, and there's not a great deal of fat, which you would expect to see with a newborn, or muscle, really. So it's a very wasted baby, but you can see that the head is of a relatively normal size. So I think overall, for me, this is a picture of a very growth-restricted baby.
Yeah. And I wanted us to think about what role the placenta might play in this picture. Gus, do you have any thoughts on that?
As Professor Dodd is saying, this looks like a growth-restricted baby, which could fit very well with a malfunctioning of the placenta that would lead to this type of babies where you see a so-called brain sparing. So it would fit with the placental problem, but there could be other causations of this.
Yeah, so let's maybe turn this to you, Claire. I know you're a placental biologist, but are there other things we should be considering as well?
Well, depending on where this baby was born, this baby could be born to a woman who was severely undernourished, but really in most jurisdictions we would expect that this placenta that served this poor baby just was not transferring nutrients at the required rate.
Great. Well, not great for the baby, but thank you. And why might that be, Gus? Why would the nutrients not be being transferred through the placenta?
Now, this type of growth restriction would typically fit with a placenta that there might be a small placenta, and the blood supply to the placenta, the so-called spiral arteries, might not have really adapted to allow the placenta to grow into spiral arteries. So there's an underperfusion of the placenta and therefore an undernutrition to the baby.
Okay, thank you. Now, I want us in a moment to develop that a little, but before we do, Jodie, could there be anything else that we should be considering about this?
Sure. I suppose from a clinical perspective, when I see women who have pregnancies like this, I don't tend to see the baby at this stage. So we would encounter the woman most often relatively early on in pregnancy, maybe around 18 to 22 weeks of gestation, where it's picked up often at the time of a morphology ultrasound, where the baby has very severe early onset growth restriction. So in that context, we'd be doing a workup to look to see if there were any other potential causes for the growth restriction, and that might include a carrier type to look for specific chromosomal anomalies or microarray abnormalities. We'd also be very interested in doing an infection screen. We would do some uterine artery Dopplers to see whether or not there was issues with placental function, and we'd also be doing other assessments for the baby. So in addition to the biometry measures, we'd be having a look at a series of fetal Dopplers that would give us an indication about the blood flow and the blood supply to the baby and the various organs.
Yeah. So we've got maybe a placental problem, maybe maternal nutrition, maybe something else, but I think we all believe that this is probably a placental problem. Why does it matter? This baby is clearly alive.
I think indeed this baby is happy to be alive, because the other flip side what we see as obstetricians is that these babies would end up as a stillbirth, because the placenta is not able to give to transfer enough oxygen and nutrition to keep the baby, the fetus, alive. So this is this phenotype, this type of growth restriction we often also see with stillbirth.
And I think also, Paul, even though the baby is alive, often the organ systems are relatively immature. So this baby would almost certainly face a period of time in the nursery and may develop a number of complications associated with that admission to the nursery.
And then there are lifelong effects of being so severely growth restricted in utero. So this baby, when it grows up, is more likely to develop chronic disease such as heart disease, type 2 diabetes and other non-communicable diseases, just because of the way it failed to grow well in utero.
Well, Jodie, you mentioned earlier that you thought this might be detected quite early in pregnancy with ultrasound imaging. If we did detect something early, what could we do about it?
It really depends on the severity of the growth restriction and the gestational age that we detect it. For those women that have very, very early onset and very severe growth restriction, sometimes termination of pregnancy is an option for them because of the significant implications for the pregnancy and also for the baby. We would, if the woman decided to continue the pregnancy, we would institute quite intensive antenatal monitoring where we would be doing at least weekly, probably twice weekly Doppler assessments to monitor changes in blood flow. And assuming we got to a point where the pregnancy was considered to be viable, we would then be using some of those ultrasound measures and blood flow measures to time delivery.
Any chance of preventing this in the first place?
Well, as Professor Roberts was mentioning, I think that this baby would be prone to cardiometabolic disease, and therefore I think that if this was a baby girl, if she's subjected to the poor intrauterine, basically the environment, then you basically see a forward loop happening that then when she's a woman and having her first pregnancy, her subsequent basic generation would also be growth restricted. So if you try to prevent if we have primary or secondary prevention of growth restriction, then you would actually also help to reduce the risk of growth restriction in the next generation.
So it's quite a significant problem, isn't it? We're talking about
very multi-layer, very complex. Yeah.
Adult life for this baby, and also for the baby's children.
Absolutely. So we can see transgenerational effects across 3 generations. So grandmother, mother and baby, and then consequently when that baby grows up, her children.
Thank you. Well, I'd like to thank the panel. I think that's been a great series of answers to a really, really difficult problem. Thank you very much.